So Sitravatinib is a multi-receptor targeting TKI, and we have a fair number of these approved already by the FDA in the setting of metastatic kidney cancer. The one unique aspect of Sitravatinib is how potently it targets a panel of receptors called the TAM receptors, so TYR3, AXL, and MERTK. And those receptors, based on preclinical evidence, can modulate the immune microenvironment in a way that can synergize with immunotherapy. So a big component of this trial was to determine through patient correlatives, blood samples and tumor samples, what are we doing when we first give this drug alone. So what we did is we first gave this drug alone for a couple of weeks, and we saw how it impacted the immune microenvironment, both in the blood and the tumors. And then what happens when we add the anti-PD-1 immunotherapy Nivolumab? Is the microenvironment impacted further in a way that can be beneficial? And if not, why? And so we connected these results with our efficacy and toxicity outcomes, and this is what we published in that manuscript in Science Translational Medicine. Another big component of that manuscript was to determine, first of all, whether Sitravatinib can be safely added to Nivolumab, and we found that it can. But an interesting and unique aspect of that trial is how we determine that. So usually we determine the dose of a drug just by looking at its toxicity. But connecting to what I mentioned before about patient values and goals, instead of just looking at toxicity, we integrated the trade-off between toxicity, side effects, and benefit outcomes, like how much does the tumor shrink, for example, or how much longer do you stay on this drug with PFS. And as an additional third dimension uniquely, to make our final dose recommendation, we actually incorporated patient quality of life. And so using these three dimensions, we finally came up with a dose that we believed had the optimal balance between toxicity, efficacy, and patient quality of life.